Defur, I want to ask you the next question. At the beginning of this whole process, President Obama said he has two goals with healthcare reform: reduce costs and improve quality. Those are big goals. But to do it at the same time, what needs to happen? What do you see as the best way to achieve both of those at the same time?
Well, I think one approach to that is clearly pay-for-performance kinds of incentives. I think that's a good way of looking at how we go about simultaneously improving quality and decreasing costs. As I mentioned before, I think primary care access and as Dr. Brater said, really looking at how do we compensate primary care, how are we supporting them, how are we getting more people to go into primary care is a key piece because primary care can be very effective in early intervention, in prevention, in wellness, and there's a lot of cost in the system today related to people not going to primary care, but rather waiting until they become so ill that they show up in the emergency department. An example of that is if a patient shows up at the emergency department with full-blown pneumonia. They may be hospitalized, put in an intensive care unit for 2 or 3 days, and then step down to a medical unit for 2 or 3 days, and then discharged at a bill of $20,000 or $30,000. When in fact, if they had gone to a primary care physician a couple weeks ahead of that, they could have been treated with $4 a day antibiotics. So for just a couple $100 for the physician visit and the antibiotics, they could have been treated and kept healthy as opposed to entering into the most expensive place in the system, which is the hospital, and incurring $25,000 to $30,000 in expense. So I think that's one of the ways, the concrete ways that we look at reducing cost. One of the other things that at St. Vincent Indianapolis that we've really jumped in with both feet on is utilizing lean process improvement methodology, taken from the manufacturing industry and implementing what's also referred to as the Toyota production model. But it really focuses on elimination of waste within our processes. Staff are on these teams and they do the work. As we know, variability is the enemy of quality. And we eliminate waste and hardwire the more efficient processes. But again, those who are involved in the processes, the staff, are on these teams and they develop it. I've also learned over the last few years in looking at lean process improvement and the implementation of it that you really do simultaneously increase quality and decrease cost by getting waste out of the system, because waste is extra steps in a process, it's duplication. And when you eliminate those things, you eliminate those additional steps, you eliminate possibility for error as well. And so I think in improving quality improvement and focusing on it, using methodologies such as lean process improvement is another way we can get cost out of the system as well as improve quality.
For the rest of the panel, do you think that go ahead, jump in, Dr. Brater.
There's no way you can really get meaningful cost out of the system unless you do something about overutilization. Let's admit it, that's a big elephant in the room. You can nibble around the edges with all this pay-for-performance stuff. That's got all sorts of issues. One of the biggest determinants of whether or not an individual adheres to a regimen, come to the clinic, taking their medications, et cetera, is health literacy. So, let's say you have a pay-for-performance plan, but your patient has low health literacy, and so no matter what your efforts are, you have trouble getting them to adhere to a certain regimen. So your pay-for-performance plan punishes you. Well, it turns out that the people with the lowest health literacy are probably the people who need your services the most. So then you end up with yet another perverse reimbursement system. So some of this terminology sounds nice on the surface, but if you drill down a little bit, there's a lot more to it than that. So, I don't want to sound like a broken record. It's, number one, it's complicated, multifactorial. Number two, there are serious, serious flaws, and I'm worried that there's too much tinkering around the edges and we're using a lot of buzzwords. And lastly, what I started with is that one of the biggest elephants in the room is that we have a system that rewards doing stuff instead of spending time with patients. So it's a completely broken business model. We are here for the IBJ, so if you want to talk about the business of it, people are rewarded for doing more and more things. Well, that's not always in the best interest of the patient. So how are we going to get our arms around that? Pay for performance doesn't do it.
Jake.
JK.
Dan Evans, what do you think about this?
Well, bootstrapping on what the dean just said, and everybody in this room, I think, can relate to this, and of course, every healthcare professional up here can. If we pay for more stuff, it doesn't matter how efficient we get, we just do more stuff more efficiently. If we're doing stuff that shouldn't be done in the first place, we're all complicit in that. And what am I talking about? Feudal care. Most healthcare expenditures are in the last few months of life. Many people in this room, because of your ages, are dealing with elderly parents right now. I know who you are. Many of you are my friends. You call one of us dealing with really profound issues. Does mom have a living will, yes or no? Does every family member understand what it means, yes or no? Did you discuss it last Thanksgiving when you all were sitting at the dinner table, yes or no? If the answer to any of those questions is no, when the moment comes, you'll become a maximum utilizer. And the tinkering on the edges the dean just talked about will not affect the profound implications of that lack of preparation. And that's a psychosocial issue in this country. What happened in the House bill where it mentioned, what was it, Kyle, $200 a primary care physician got paid for counseling one time a year? One time a year, a family could get counseled and the doc could get reimbursed on palliative and end-of-life care. And instantly, that was converted into a death panel. So that became the third rail. Wow, did those guys drop that one right away? But you know what I'm talking about, because you know whether or not you have a living will and medical power of attorney, and you know whether or not your family, your siblings, your children understand what it means for you. And this is deeply personal. And that's part of the 50% that Dan was talking about. I don't know what part of it is to you, Dan, but it's got to be in double digits. Anyway, the general assumption is that a third of critical care is futile. Doesn't make any difference. The patient dies in 2 months. Anyway, who decides in our culture who gets the care and who doesn't? If you were an actuary from Mars and landed here and had a choice of $1 million to spend on an 80-year-old or an 8-year-old, you know what you'd do, right? We do not make that kind of decision. We pay people for more stuff, so we have overutilization. The hospital systems in Indianapolis do the best they can to be more and more efficient, but essentially doing the same stuff. So the only way to cut healthcare costs, and it's implied in many of the articles you read, is eliminate innovation. Who's in favor of that? That's one quick way. Just get rid of innovation. No more improvements in medical care or ration care. Who's in favor of that? I believe I just heard a resounding nobody in the room, which means status quo.